3.
So thanks very much, Mr. White, for coming in. So the purpose of today is to talk about cardiac devices. So you have been diagnosed with heart failure, and one of the treatments for that is to have a particular cardiac device. And what we'd like to use this film for is to demonstrate to other patients the sort of things that happen in the consent process. So we're going to talk a bit about why you're having the procedure, what it involves, what the risks and the benefits are, and then what sort of information might be useful for the future. That will then give you an opportunity to ask any questions that you might have, and hopefully that will provide material that the public, if they're, or future patients, they can then use that in their own decision-making process to help in their own healthcare. Okay.
Fine, yes, that sounds very sensible. I'd like to know a bit more about exactly what the process is and how it works and what I should expect.
Okay, so to begin with, the heart is obviously a very complex organ, and one of the problems that can affect it is heart failure, and the reason that is a problem is partly symptoms, so patients can have breathlessness, dizziness, swelling of the ankles and so on, but also it's a risk factor for dropping dead, being completely frank about it, for having a heart rhythm problem that can be fatal. And so in a proportion of patients, they are risk assessed and then offered a procedure that can try and treat and prevent those problems. So in a normal heart, it functions like this. So it squeezes away and blood is squirted out around the body to the arms and legs and brain and so on. Now, in your case, your heart, it wobbles rather than squeezes in a nice synchronous fashion. So one wall is coming in as the other one is moving away. And you can imagine that's not a very efficient way of the heart pumping. Now, the standard pacemaker has something called a lead on one side of the heart, and then it has a lead on in the top chamber and the bottom chamber, and all it essentially can speed the heart up if it's going too slowly. Now, the sort of device we're planning in yourself is called a cardiac resynchronization therapy device, and that's very special because it has a lead on one side of the heart and also a lead on the other. And you imagine if you're stimulating both at the same time, then you can resynchronize the heart and therefore make it more efficient for blood pumping around the body. So the main benefit of that to you is improvement in symptoms, and I would expect 2/3 of patients, at least in your situation, to feel a significant benefit. So less problems breathing when you exert yourself, less breathlessness at night, less swelling of the ankles, and more energy and ability to do work.
What has caused that to happen in the first place, or would I have always had that, or is it just something that has developed more recently?
So there are lots of different causes. The most common cause is problems with the heart artery, so heart attacks. So people who survive a heart attack but are then left with a weakened heart afterwards. But there's a list as long as your arm, so problems with the heart rhythm, endocrinological problems, family history, so about a third of cases actually in people who have got another family member affected. And those are particularly important because we can then screen other family members. Problems with high blood pressure, so there really are an enormous number. Now, in some ways, it's a bit like a broken arm. It doesn't matter how you broke it, you treat it in the same way, and that is with medication. And so the medication is absolutely the most important thing. I know we've established you on all the right medication.
Yeah.
But if medication isn't enough to improve the pumping function, then that's when we look at devices such as what we're
and the fact that I've been sort of getting breathless, going for walks and things like that, is the sort of typical cause that you're talking about.
Yeah, that's probably the most common symptom that patients present with.
And something that I'd be really keen to improve on.
Absolutely.
That hopefully will give me the opportunity to get back to doing normal exercise again.
I would hope so. I think in your particular case, I think there's a very good chance. I would say, at least 2/3, but probably a lot higher than that, of improving those symptoms because of this synchronization that we talked about. So I think that's the main benefit in terms of symptoms. The second component of this is about the risk of dying suddenly.
Sure.
I think it's really important that we're frank with patients about that. Now, people with heart failure, some of them are at risk of abnormal heart rhythms, And worst case scenario, they can be fatal. Now, you can combine a CRT device with something called a defibrillator, and they have they much the same way. They have a lead that goes in the heart and a generator. I'll come on to that in a bit. But essentially, they think of it like a life insurance policy. They're not designed to make you feel any better. They're designed to save you if you have a life-threatening heart rhythm problem. And so they monitor the heart the whole time, 24 hours a day, 7 days a week, and if they see an abnormal heart rhythm that could be fatal, they can either give some very fast impulses to the heart, and that can often stop it, and you would be unaware of that. Or the worst case scenario is they can give an electric shock to the heart to restart it. Now, if
that sounds rather sort of concerning.
It is, well, it can be quite dramatic, but I think the important thing to realise there is that if it's doing its job properly and you're being shocked back to life, then you would have passed out by that stage. So you would be essentially on the floor in the process of dying, and then it would bring you around it.
Yeah, sure, I understand.
While we're on that though, you have actually alluded to another important point, which is something called inappropriate shocks, and that is one of the risks of the procedure. So these devices are very clever, and they've been around 20 years, and over time they've got a lot better at recognising what proper abnormal heart rhythms are, but they can get things wrong on occasion, and so we call it inappropriate shock therapy, and that is the device thinks that it's giving you a shock to save your life, but it's got it wrong, and you're actually still awake, and that can be it can be painful, feel like you're being punched in the chest. B, there's the psychological aspect of that, which certainly shouldn't be ignored, because that is obviously a worry moving forwards. Now, though to say that those rates are low, and estimates of exactly what they are vary, but it's probably of the order of about 1% a year, something like that.
Oh, so it's quite low.
It is quite low, but if it happens...
What do you do if it happens?
So the monitoring of these devices is often done remotely now. So you will be issued with a box that sits in your home, and that can talk to us over the internet. Now, if the device should give you a shock on any one day, that will automatically tell us over the internet that it's given a shock, and then we can contact you and check things are all right. If, however, let's say the scenario where you have an inappropriate shock, you'll always be able to contact us, and we can either bring you to hospital or organise a remote monitoring check so that we can see how the device does, see exactly what's happening.
So this box, where do you keep it in the house?
It just needs to be near a phone point. So,
yeah. And that sends back messages every evening, or does it send?
So it will not necessarily send routine messages unless certain thresholds are reached. For example, having given a shock, or if it notices that there's a particular problem with one of the leads, for example, but that is very rare. Then it will notify us. Otherwise, we will contact you at predefined intervals, let's say every 6 months, and then you would do what's called a manual download to tell us here are the parameters on the leads and so on.
Sure. So once you've had this fitted, it's important, if you feel any abnormalities, to contact the hospital.
Absolutely.
And be reassured that.
Absolutely.
Because it's obviously quite a big procedure psychologically having one of these fitted. Here you are thinking you're reasonably fit, or you may be getting breathless. And so what other risks are there involved in having it done? I understand the risks for not having it done, but what about the risks involved in the whole procedure and going forward? So
there's the risks of the procedure itself are overall, there's about a 5% risk of a problem during the procedure itself. To explain what happens, you'll be in what's called a cath lab, so a bit like an operating theatre, so it's a sterile environment. There'll be a bed in the middle, there'll be a variety of people there, so I'll be there doing the procedure, I'll have an assistant, there'll be a couple of nurses there, there'll be a member of staff to control the x-ray machine, and there'll be a physiologist who checks the measurements on the device as well. So you'll lie on a bed, and we'll give you what's called conscious sedation, so you'll feel very sleepy, but you won't be, it's not a general anaesthetic, although a lot of patients do sleep through the procedure. We'll clean the skin at the top of the chest, usually in your case on the left-hand side. Occasionally we do it on the right, but mostly it's on the left-hand side. So we clean the skin. and then you'll have some drapes put over you, and I'll make a small incision, a couple of inches long, just under the collarbone there. Then I'll there's a vein that runs under the collarbone and down into the heart. I'll access that with a needle, and through that vein, that's where these wires are put in. In your case, there'll be 3 wires. Right. So one at the top, one at the bottom, and then one that goes round the side.
And it's the one round the side that is the resuscitation.
No, so the one around the side is the one that improves the squeezing function of the heart, and it's the one of the other leads that has the resuscitation part to it. Once the leads are all in, I'll make what's called a pocket, so essentially a hole for the device. Yeah. That can be a bit uncomfortable when I first make it, because obviously you're making a space for the device, but it will literally last for a second or two. It shouldn't be too uncomfortable. Yeah. Once the pocket's made, then that's where the device sits, and I'll show you one at the end of this talk, so that you can actually have seen one. And also, when you come into pre-assessment, you'll get an opportunity to see one as well. And then essentially it all gets sewn up, and that's it, finished.
So it doesn't cause any discomfort, or it doesn't mean that you can't use your arm like you did before, or anything?
That's a good question. So for the first month, some people say 2 weeks. Personally, I prefer to a little longer than that. I would ask you not to put your arm above shoulder height, or not carry heavy shopping, that sort of thing, because you can imagine if you have the wiring like this, and you go to reach for something on the shelf, there is the potential for dislodgement, and so that risk in the first month is about 1%. And if a lead works, so the process is we bring you back 1 month after the procedure, we check all the device and so on, and if it's working fine, obviously great. If there has been a problem with one of these, that would necessitate another procedure to put that lead back again.
Then presumably the body heals around the leads.
That's right, the body does.
Yeah.
There's also, so in terms of the other risks, there's an infection risk, so we give you antibiotics beforehand to cover the procedure. We'll ask you about obviously relevant allergies and so on, but you'll have antibiotics to cover you. But the risk is probably about 1% of an infection at the time of the procedure. Now, the batteries of this device will last. It depends a little bit on a few parameters which are variable, but probably around the 8 to 10 year mark, something like that. And at the end of that, you would need a generator change. That's a smaller procedure. Having said that, the risks of infection are higher because you're already opening up something that's been there. And so there's those risks to take into consideration as well. Now, and we'll obviously follow you up and tell you when.
So how do you know when the battery is getting?
So with the monitoring that you talked about earlier, that will tell us what the battery status is.
So I then sort of have it checked sort of half yearly or once a year.
That's right.
And you tell me how long the battery is, whether the readings are right.
Correct.
And then I can give feedback onto how I'm feeling.
Exactly so.
So can the device be adjusted so you might want it to work in wider parameters?
Absolutely. And often the parameters that are set when it first goes in are not the same as 1 month down the line, and even thereafter as well. They're enormously complicated nowadays, and you can make all sorts of electrical adjustments to try and optimise the device to make sure that it's tailored for you as much as possible.
And does it ever happen that the device repairs the heart or gets the heart back so it is pumping correctly, and so therefore the need of the device is not so important? Is that not true?
Absolutely. So there is good data to suggest that the heart we call it remodeling, which means the actual shape of the heart can change because it's being resynchronized, hence the reason for improvement in symptoms. Now, the bit about is that then a reason, could you take it out, is that the worry is obviously you go to the trouble of taking it out, and that can be a big procedure, and then you're back to square one, so we certainly don't advocate that.
So you're better leaving it in and turning the volume down a bit, as you might say, or the power down.
Exactly so.
Yeah.
If I could just finish up about the rest of the procedural risks. When the leads get put in under here, there is about a 1% risk of making a hole in the lining of the lung when they go in. If that happens, it sounds very dramatic, but it's normally nothing further needs to be done and can be managed conservatively. We would check chest X-rays, but you need to be in hospital for a few days afterwards. On rare occasions, and I think probably about once a year in this hospital, we would need to put a drain in to try and drain off the air that's accumulated. In the similar fashion, you can make a hole in the lining of the heart when the leads goes in, and that's about a 1% risk.
Yeah.
Now, in those cases, often if that happens, then we do need to act fairly quickly to put a drain, so a small tube that just goes under the rib cage here to drain off the fluid. Again, it's rare, but you need to know that.
But you can't go and have any hospital procedure without there being some risk. The benefits is what you're saying far outweigh the risk.
I mean, we're talking about at least a 2/3 risk of benefit versus a 5% risk of a complication.
Sure.
In terms of how many patients do we have to treat with one of these to save a life? So we're probably talking the order about 1 in 10 on our local. So we've audited our own practice in Bournemouth, and for about every 10 that go in, one person has their life saved. So if you're the 1 in 10, fantastic.
Yeah.
But of course, if you're one of the 9, then you've had that procedure unnecessarily.
Yeah.
Of course,
we
we can't predict that any more robustly.
Yeah.
But in your case, you also have the benefit of the squeezing function.
Mm-hmm.
A couple more things to talk about. Now, obviously, having a defibrillator is all well and good if you're otherwise in good health and so on, but God forbid in the future you should develop a cancer or something like that. Now, it wouldn't be, in the same way, it wouldn't be appropriate to put a defibrillator into someone who had a very short life expectancy from another reason, such as cancer. And so, should something like that happen to you in the future, it's possible to deactivate the defibrillator component of this without another operation or anything like that. So, I have had patients who have another health problem later on, and they get very worried, of course, about, well, now we're giving me a shock and all the rest of it. And so that's absolutely not the case. We can make those sorts of adjustments electronically.
So, at the end of life is what you're talking about,
Exactly.
which may be old age, or it may be some other thing that you've got, that you can sort of say, look, I think I can come to you and say, I would like that turned off. I'm now 92 or whatever it may be,
Exactly
and I think I'd just like to.
Or even when the batteries run out, you might come to the point and think, do you know what? I'm happy now that I don't want anything else doing. Let's leave it. Absolutely.
So you can just leave it in there with the done batteries, you might say.
You can do. It's rare that we do that, of course,
but you could.
It is an important point on what happens if there is a problem that infection would be the most obvious cause. So let's say, God forbid, but you should get an infection of the device in later years. Now that can be a real problem because the longer something has been left in you, as you alluded to earlier, your body sort of grows round things, and that can cause a real problem because you have to try and take it all out. Now, if something's been in for a year or two, or a few years even, it's normally not a problem. If the leads have been in for 20 years, then that can be a real challenge. It's certainly not insurmountable, but it was a larger procedure to take it all out, and there is a risk of dying in those procedures, particularly if they've been in there for an awful long time. It's just worth having.
But it can, on the other side, it can enhance your quality of life so much that the benefits outweigh the
studies
risks
in this technology are overwhelmingly positive in terms of benefit, with symptoms, improving your quality of life, reducing your risk of coming into hospital, reducing your risk of dying. It's been very well proven. Is there anything else that you're worried about or interested in, or?
No, I think that sort of psychologically, it's I've been worried about having been to you for consultations and realising that I should have the procedure done. That I think that will help in giving me more confidence in what I'm at the moment. I'm just sort of a bit worried, and if I go anywhere on my own, I'm a bit sort of concerned. Perhaps I should let somebody know where I am, because, as you quite rightly said, you can without it, I could die quite suddenly. So I think that the fact that we're considering having it done, another very positive reason is to restore my confidence and my ability to do things on my own and get out and get back to leading a normal life. I think that was really, one of the driving things for me.
I think that's a really good point, and of course the psychology of these devices is huge, and there are positive and negative aspects to it, but one of the main positives is having patients having the confidence and that they know that they're getting monitored and that they have that backup in place.
And how soon after the procedure's been completed will I feel that I can get back to normal, or do I have to take things gradually for a month or 6 weeks and build up slowly?
So typically you'd be in hospital. Most patients stay in overnight. It depends what time of day the procedure's done. If it's done first thing in the morning, then you might well get out that later that day. My lists are in the afternoon, so you would most patients would then stay overnight and go home the following morning. The skin heals up over the first week, so I would use dissolvable stitches. There's no stitches to come out, but you'd have a dressing on it, and we'll talk to you all about wound care at the time. But the first probably few days you'd be a bit sore, but simple painkillers, paracetamol is normally sufficient. You would then, so after a week, so you can wash and shower, but you have to keep it dry for the first week. And then I'd take it easy for the first month, I think is reasonable. But you may get, some patients get back a bit sooner than that. But I would certainly think after your 1 month check, you'd then be in a position to go and live your life. The benefits, often people do notice it very quickly actually, but the remodeling process I talked about, so the change in the heart structure, that can take months, so you'd expect to see incremental benefit as time goes on.
And when you start taking exercise, there you are with the device implanted there, and it's going to help your heart beat together, as you might say. Does that sort of, when you start off doing exercise, does it have to sort of catch up and sort of before you really feel the effects of it, or because it obviously can't think what you're
it's a very good question. So although they can't think, the devices these days are very clever in terms of how they sense that someone's doing exercise or work. So most of them, the different manufacturers have different algorithms to work it out, but one of the common features is something called an accelerometer. So it's essentially a piezoelectric crystal that can sense movement, and so if it thinks that you're moving, then it can increase your heart rate. Now in your particular case, your heart rate is normal anyway, and so that's less of an issue. The sensing of the heart rate is more of a problem for people whose own intrinsic heart pacemaker has slowed down and isn't giving them enough heart rate.
So I can go back to playing tennis or playing golf if I want to, or going on walks. And what about a game like squash, where it's a sort of very 1 minute you're just wandering around, the next you're sort of dashing to a corner to try and save.
No problem at all. So in terms of sort of environmental things, you can go swimming, anything like that. The only issues with interference, let's say, are from large electromagnetic interference sources. So, for example, arc welding. If you're an arc welder, then you would have to look at your occupational history. Some induction hobs, and so you have to be a bit. As long as you're with cookers, but within a certain range of those. But it's not normally a practical issue that we have to be too worried about. People used to worry about mobile phones, but that's essentially not really. Well, we tend to advise using other ear and so on, but it's not in practice. There's been problems, that's for sure.
And so that in some way could sort of upset the working mechanism.
So it's more about it's not so much upsetting the mechanism, it's if there's a large electromagnetic source, then the device, we call it sensing, it thinks it's seeing something that's not there because of the EMI. But in practice it's not. But something else I was going to touch on was in terms of support, and you mentioned the psychology of it, and we have something called the Bournemouth Area Defibrillator Support Group here, because a lot of patients do feel benefit from speaking to other patients who have got the device, and so we would talk to you about that at the time. And
that's a very good idea.
Absolutely. So it's a really well supported group. I've spoken at it myself now. So for people who there will always be questions that crop up after the event.